Hey guys, it's John Spoostek. I'm here to talk to you all about mitral valve stenosis. I chose this topic because I'm very interested in the different valvular disorders, and I just wanted to tell you all a little bit more about it. So, throughout this PowerPoint, we're going to talk about the general features, clinical assessment, so the signs and symptoms, as well as what you may see or hear on physical exam, how to diagnose, and treatment of mitral stenosis. So, let's get into it. You may be thinking, what is mitral stenosis? Well, mitral stenosis is a form of valvular heart disease characterized by narrowing of the mitral valve orifice. And worldwide, rheumatic heart disease is the most common cause of mitral stenosis. And this is caused by untreated or inadequately treated streptococcal infections like strep throat, and it causes an inflammatory process between the valvular tissue and the streptococcal antigen. This causes tiny nodules to form on the valve leaflets, and the leaflets then begin to thicken and narrow, obstructing the flow of blood from the left atrium to the left ventricle. Another cause is congenital heart disease, calcifications of the mitral leaflet, and this usually occurs with old age, and inflammatory or autoimmune conditions like malignant carcinoid syndrome, lupus, and rheumatoid arthritis. So you may be thinking, what are some signs and symptoms of mitral stenosis? Well, symptoms usually arise later in life. In the case of rheumatic heart disease, it's usually 20 to 40 years after the episode of rheumatic fever. If your patient presents with orthopnea, P&D, fatigue, weakness, and shortness of breath with exertion, you should put mitral stenosis on your differentials. The normal mitral valve orifice is 4 to 6 centimeters square. Mitral valve areas less than 2 centimeters square cause a barrier to the blood flow from the left atrium to the left ventricle, and this can cause complications like left atrial enlargement. In this case, your patient may present with palpitations, chest pain, hemoptysis, and thromboembolism. So you may be thinking about those numbers that I told you, and you might be saying, what do those even mean? Well, in early stages of mitral stenosis, the patient is usually asymptomatic and their valve area is between 1 and 1.5 centimeters square. Patients usually become symptomatic when their valve area is less than 1 centimeter square. And as the disease progresses, symptoms tend to worsen. Fun fact, 1/3 of patients will develop AFib. On physical exam, you're going to hear a heart murmur, and it's going to be a diastolic rumble with an opening snap. The murmur is best heard at the apex of the heart in the left lateral decubitus position with the bell of your stethoscope. It'll increase with squatting and hand grip and decrease with standing and Valsalva. The opening snap is heard shortly after the second heart sound, your S2. So in this picture, your opening snap is right after your S2. And this sound occurs when the mitral valve opens abruptly. You may also hear a loud first heart sound, so your S1 is going to be loud due to an increased resistance to flow across the stenotic valve. In severe cases, a palpable thrill may be felt over the left sternal border, and as the disease progresses, your patient may be showing signs of right heart failure, like elevated JVP, hepatomegaly, and peripheral edema. In order to diagnose mitral stenosis, you can use non-invasive tests or invasive tests. And the gold standard is going to be an echocardiogram. This is because it provides information about the degree of stenosis, the size of the left atrium and ventricle, and the presence of any associated complications like mitral regurg or pulmonary hypertension. The ideal window is going to be your parasternal long axis window. This is because it can identify the characteristic diastolic doming of the mitral valve. In the image below, this is a parasternal short axis, and the image on the right is going to show a nice skinny normal mitral valve, and the one on the left is going to show a thick mitral valve that's going to cause all those symptoms that we discussed on the previous slide. Other options are EKGs, which can show P wave changes, which suggest left atrial enlargement, or it may show right axis deviation and right ventricular hypertrophy, which suggests severe pulmonary hypertension. You can also use a chest x-ray, which will show signs of left atrial enlargement, pulmonary congestion, and pulmonary hypertension. You can use exercise testing, which is used to assess the functional capacity and symptoms in patients with mitral stenosis. And your invasive test is going to be your cardiac catheterization, which is less commonly used for routine diagnosis. It's usually used in cases where intervention, like we're going to talk in the next slide, is being considered. Treatment includes medical therapy, which is focused on preventing endocarditis, reducing the recurrence of rheumatic fever, improving symptoms, and decreasing the thromboembolic risk. Preventing endocarditis is accomplished by prescribing antibiotics like penicillin G in patients before any dental procedures. Improving symptoms can be accomplished by prescribing diuretics if they're fluid overloaded, and calcium channel blockers or beta blockers to help with exertional symptoms. Preventing thromboembolic events includes anticoagulation in patients with AFib or other risk factors for blood clot formation. PMBC is the preferred treatment option for patients with mild to moderate stenosis due to its high procedural success rates and low mortality rates. And in this picture, it kind of shows you what PMBC is. So they stick a little catheter all the way up your IVC. They make a hole between your two atriums, and they stick this catheter with a balloon tip through your mitral valve, inflate it, expand it, and open that mitral valve a little bit more. Surgery is also another option, and it's indicated in patients with severe stenosis or those who cannot undergo PMBC. Surgery options include mitral valve repair and mitral valve replacement. Replacement can be accomplished using a bioprosthetic valve or a mechanical valve. But valve repair is the preferred surgical method, and this is because bioprosthetic valves require frequent intervention and mechanical valves require lifelong anticoagulation therapy. Preventing the number one cause of mitral stenosis is prompt treatment of streptococcal infections. So if you can treat that infection and make sure that it does not cause any complications, you can prevent the number one cause of mitral stenosis. Here is a list of my references. If you have any questions at all, please email me. And if not, thank you for watching, and I hope you learned something.